All right, welcome everyone. Thank you for joining us today. I'm going to hand over to Henry Bonsu to kick us off with this ministerial panel.
Thank you very much. Merci beaucoup. Welcome to From Resolution to Reality, Accelerating Progress on Maternal and Child Survival in Africa. I'm Henry Bonsu, a journalist and broadcaster from Ghana and the UK, and I'm delighted to be your moderator for this. Or good evening, bonjour et bonsoir. This discussion is convened by the Child Health Task Force and Market Access Africa, who are part of Child Survival Action. It's a movement to address the unfinished agenda of ending preventable child deaths and accelerating progress toward SDG 3.2. Now, this is a ministerial panel discussion, and we have a stellar lineup of ministers and high-level speakers who took part in those key World Health Assembly discussions leading to the landmark resolution. And let me welcome them. They are the Honorable Dr. Ali Haji Adam, Minister of Health and Social Care from Somalia. We have the Honorable Professor Charles Sinesi, Deputy Minister of Health and Sanitation from Sierra Leone. We have the Honorable Dr. Dieni Fadima Kaba, Director of Family Health at the Ministry of Health and Public Hygiene of Guinea. And we have Dr. Abdoulaye Guindo, Secretary General for the Ministry of Health and Social Development, Mali. We also have Dr. Matshidiso Moeti, the WHO's Regional Director for Africa. And we hope to be joined by the Honorable Professor Randria Mananantani Zele Arivelo, Ministry of Public Health, Madagascar. I'm pleased to see we have a good number, several hundred participants logged on. Our audience today is made up of technical officials from ministries of health, advocates and civil society organizations, primarily working in maternal and child health, development agencies, private sector, and concerned citizens. Now, I'd like to say at the outset that this will be a dialogue, not a speech. I will pose questions in both English and French, anglais et français. And we do have interpretation. You can see it there at the bottom of your screen, both in English and in French, clearly marked. Participants, please feel free to put your questions into the chat at any time, and we'll try toward the end of the webinar to put some to the panel. Now, before we hear from our specialists, let me try and set the scene briefly. In the 30 years between 1990 and 2020, the world has seen dramatic progress in maternal and child survival. However, African women and children have not shared equally in this progress. The number of maternal deaths over the period actually increased by 9% across Africa, and the decline in child deaths was just 30%. As a result, today, 55% of global maternal deaths occur in Africa. That's 55%. And more than 50% of all global child deaths also occur in Africa. However, the story of maternal and child survival in Africa has the potential to be a verifiable turnaround, a completely different story, a triumph of political leadership for public health, a testament to the power of innovation, new tools, and international partnerships, leaving a legacy that will strengthen economic and social development for the next generation across the entire continent, but only if we finish the unfinished business. Now, we also know a lot more than we did about maternal and child deaths across Africa. For example, we know that the majority of deaths occur in the period after the first month of life, the post-neonatal period, among children aged between 1 and 59 months. Now, these children are dying from malaria, pneumonia, and diarrhea, with malnutrition being a key risk factor. The SDG 3.1 target requires every country to reduce maternal deaths to less than 70 per 100,000 live births, while SDG 3.2 calls on each country to reduce child deaths to less than 25 per 1,000 live births. We're now less than 6 years away from that deadline. Globally, 64 countries are projected to have a maternal mortality ratio greater than 70 per 100,000, and 70% of those are in Africa. That's 45 countries. When we look at SDG 3.2 projections, 59 countries are off track, and 76% of those are in Africa, as you can see in the map there. That's 45 countries are in Africa. Now, it cannot be denied that African countries have and are continuing to make important strides to end this tragic situation. But African health leaders, some of whom are gathered here today, are calling for greater, more urgent, accelerated action. The Honourable Dr. Austin Demby put it very starkly in a powerful opinion piece, and I quote him directly: "This is our problem, and no one is coming to save our children." Concerned by this situation, Somalia initiated and orchestrated a global resolution on maternal and child health. This was a landmark move adopted at the recently concluded World Health Assembly. Now, although it took a masterful orchestration to get the resolution adopted, it is only the first step in a long process. Now that UN member states have committed to take measures to accelerate the reduction of maternal, neonatal, and child health, here's the key question: what will it take to move us from resolution to reality? How do we ensure that this policy instrument has the desired effect, and that ultimately we see the end of this tragedy of common but preventable and treatable deaths of mothers and children? Let me start with Dr. Moeti, the WHO Regional Director for Africa. And Dr. Moeti, thank you for being with us today. I would like to ask you to provide further context to this conversation by highlighting, first of all, what has Africa's trajectory been regarding maternal, newborn, and child health goals, and how is Africa progressing toward achieving the maternal and child health SDGs? Dr. Moeti, over to you.
Okay, thank you very much, Henry, and good afternoon, good morning, good evening. First of all, honorable ministers and panelists, and to everyone who's joined this session, showing your concern about progress in maternal, newborn, and child deaths in Africa. I think, first of all, just to start off by saying that one of the things that's very important, of course, is political commitment and decisions being made and owned by African leaders. And I think we do have that. For example, since the year 2000, we've had declarations made at the level of the African Union and by our member states or ministers at the World Health Assembly in the past and at the Regional Committee on improving the health and lives of women and children, including adolescents. And we did see some progress in our region. I won't go into the numbers in detail, but I think these can be found, that there has been some progress since the year 2000 in reducing preventable stillbirths and maternal, newborn, and child mortality. So this went faster during the so-called Millennium Development Goals era, but has slowed down since the beginning of the era of the Sustainable Development Goals. So I have to commend this initiative to have this discussion. It's timely, following the adoption of the resolution at the global level in WHO, and really underlines the need to refocus attention, investment, and the lessons learned on this critical agenda, because our continent really needs it. We need the justice in terms of these deaths, and then we need the human and economic development that will result from reducing child and maternal deaths in our countries. So we've seen variable progress across what might one call the sub-regions, and Western and Central African sub-regions are generally performing less well than Eastern and Southern African regions. So we've seen 7 countries that have attained the SDG country targets for maternal mortality, 5 for under 5 mortality and 5 for newborn mortality, and others that have registered worse mortality rates than they did 10 years ago. And I'd like to emphasize that even within countries, there are several variations of mortality at the subnational level. So we need to look beyond the national figure and try to see within countries, where is it that we find the most deaths? What is going on in these areas, districts, communities? The variations across subregions and countries are driven by a few factors. One, because many countries that have attained maternal, newborn, and under 5 mortality targets are higher income countries with sometimes better developed health systems and some with a strong focus on primary health care. So it does need investment in health by the country. And I'll speak in a moment about, of course, investment from international partners and how that might be adapted so that it has a better impact. Then secondly, mortality is higher in progress, less in countries affected by recurrent or protracted humanitarian crises or conflicts, including progressively those that are driven by climate change. So we need to be looking at what is happening either in the whole country or in areas of the country as far as these factors are concerned. And then, of course, we've seen the countries that were affected by the Ebola virus disease outbreak in 2014, 2016 worked very hard to emerge from that. They are affected, and what happened with COVID, which affected access to services. We're having at the moment what one can call a measles, almost a continental measles outbreak, because health service access was stopped by COVID-19 pandemic. Then early nearly one third of under 5 childbirths in low and middle income countries occur in households with children who have never been vaccinated. So we also need to look at a key prevention intervention, which is vaccination of children, and know that in some countries we have a significant number of children who have never been vaccinated. And this has been one of the impacts of COVID-19, of course, which stopped services at a certain progress in time.
And Dr. Moeti, if I can just intervene, just as a follow-up to what you've said about the variations both between countries, between the southern countries and the northern countries in Africa, the variations within families internally, what technical interventions is the WHO Africa region prioritizing and championing to accelerate progress so that we see a leveling up across the continent?
Yes. I mean, WHO has disseminated what we consider to be proven, cost-effective interventions throughout the life course to save the lives of mothers and children. And we are working on supporting countries to adopt them. And these need to be delivered using various strategies and platforms through the public and private sectors. And not only at the national level, not only in urban areas, but need to get down to distant rural areas, including very much engaging communities and working at community level. And we know that what is important, of course, is prevention in terms of the role of vaccination, the role of access to treatment for some of the major child killers, pneumonia, diarrhea, access to clean water, which demands working across sectors. And then for maternal health, ensuring that services are available right down to the most peripheral level for women to have antenatal care much earlier than is occurring at the moment, requiring then mobilization at the community level so that women know, families know, women are enabled, and communities are aware that this is something that needs to happen early rather than later as far as this is concerned. I'd like to also say something about adolescents, younger women, because we see that the rate of maternal deaths in adolescents in Africa is rather higher than occurs in other regions. So we need to be very clear about protecting the rights and safety of women as they are transitioning into adulthood, to stop early marriage. Very happy that this has just been agreed in one country stop FGM, female genital mutilation, and really to make sure that young women are enabled, empowered to be able to say no to a sexual relationship that will endanger them in terms of an unwanted pregnancy, and clearly to make services for all of this available. Equity is a very important consideration. So we need to make sure that, for example, zero-dose children and communities where they occur are targeted to reach them. That requires that we have the data. We have data that enables us to map and to know where it is that we have the most gaps in access to services around all these areas. Luckily, these days we have access to technology. I'm very pleased to see, particularly among young Africans, including health workers, the use of technology generally, so that we need to have, real-time information. I've been very inspired, and I'm sure the Deputy Minister from Sierra Leone will say how the Minister has decided to regard a maternal death in Sierra Leone as an emergency, in the same way as we regard a case of cholera as an emergency, and count those in real time rather than looking at data 2 years down the line. So we need to use technology innovation. And then just finally, so as not to talk for too long, investment, financing is extremely important. One of the shifts that are needed is to ensure that we invest at different levels, including, as I said, at the primary care level. We integrate the way in which we are investing our resources to get a better outcomes out of the money, so that we moderate some of the vertical program-related financing that's been going on for a couple of decades, which was justified. Now it is time to make sure that we have a more people-centered approach, integrated financing. And I'm very happy to see that the global health initiatives like the Global Fund and Gavi are adopting now a more integrated way of financing the health systems right down to the community level, including ensuring that we have community health workers that are in touch with the communities. I think if we
that's an excellent development, Dr. Muti. I'm going to have to stop you there. Thank you very much indeed. You've given us a great basis on which to proceed with this webinar. Let's move now to our discussion of that maternal and child health resolution at the World Health Assembly 77 just concluded in Geneva. I'm going to bring in the Honourable Minister, Dr. Adam from Somalia, because you really did help to spearhead and drive forward this process. Let me ask you this first of all, what motivated you, what motivated Somalia to put its hand up and lead this process and bring together the coalition of other governments that supported and sponsored the resolution? Honourable Minister, Dr. Adam, over to you.
Thank you. It's a pleasure to be able to join you for this webinar. And thank you for that question. Somalia was motivated to lead the process of rallying other member states around the lack of progress on maternal, newborn, and child mortality reduction, because Somalia has the highest rate of maternal, newborn, and child mortality rate in the world. Concerned by these statistics, the stagnation in maternal survival and decline in progress in child survival globally, we submitted the resolution to accelerate the reduction of maternal and child mortality in order to achieve the targets set in the United Nations Sustainable Development Goals 3.1 and 3.2. The objective of the resolution is to address the direct causes of maternal and child mortality, but also the indirect causes related to health systems bottlenecks and the underlying social determinants of health. Most maternal objective of the resolution is to address the direct causes of maternal and child mortality, but also the indirect causes related to health systems bottlenecks and the underlying social determinants of health. Most maternal, newborn, and child deaths occur from preventable and or treatable causes, underscoring the importance of the taking primary health care approach and working together to guarantee universal health coverage. After all, any child, irrespective of where it is born, should have an equal chance to survive and thrive, and no woman should die bringing a life into this world. So, from that perspective, as Somalia is one of the highest countries experiencing the worst country in the maternal and child life, we have submitted this resolution.
Thank you, Dr. Adam. Let me develop what you said, because the resolution is prioritizing all these key areas, including the investments. What about the resources necessary? Because you heard Dr. Mweti saying a moment ago that the higher income countries have been able to make greater investments and have seen more results. Somalia has been through so much turmoil over the years. So how are you working toward the resources necessary to implement these various priority interventions, including strengthening primary healthcare? The investment, please.
The strategies Somalia is putting in place to increase resources for health are building strategic partnerships with international donors, NGOs, and UN agencies to support one plan, one budget, and one monitoring and evaluation framework to avoid duplication of efforts and maximize the impact of resources. Currently, the government is focusing on liberating the remaining areas from the terrorist group, because Somalia most challenges still there is some districts and rural areas that are inaccessible by the government and partners, because they are controlled by a terror group called Al-Shabaab. So within 2 years, Somali government succeeded to liberate large area from these groups, and now we are trying to reach this area by health services. So now the government is focusing liberating the remaining area from the terror group Al-Shabaab, but we are in discussions with the Minister of Finance to increase the allocation to the health sector, particularly for primary health care. We are going to build maternal and child health centers in the liberated area to train midwiferys in this area. Some areas in Somalia didn't get any health service for more than 17 years or 18 years that these groups were controlling. So we are also exploring opportunities for the collaboration with the private sector to finance health services and to utilize humanitarian funding to both address the emergencies, but also build resiliency and to empower communities to increase ownership. Thank you.
Thank you very much. And just briefly about the focus on those vaccines for pneumonia and diarrhea later this year. It would be good to know about how you plan to implement that, how crucial that is.
From Somalia's point of view, besides the nationwide introduction of pneumococcal vaccine and rotavirus vaccine, which are planned for Q4 of this year, we welcome the work of every newborn action plan ending preventable maternal mortality and child survival action, because for us, the urgency of the situation highlights the need for in-country partners and donors to work together, not duplicate efforts, and support the plans of our national government. With the endorsement of this resolution, all governments, including mine, are renewing their commitment to maternal, newborn, and child survival by increasing investments to these areas in their national health plans. We also understand that indirect causes related to health systems bottlenecks and the underlying social determinants of health are contributors to our failure to achieve the Sustainable Development Goal targets. Rising rates of malnutrition, poor water supply, sanitation and hygiene, low health literacy for young people, and the impacts of conflict, climate change, and COVID-19 pandemic need to be tackled not only by the health sector, but using poor water supply, sanitation and hygiene, low health literacy for young people. We need to be tackled not only by the health sector, but using whole of government approach. Only with adequate political commitment to address these and other underlying determinants of health, we will unlock the acceleration of maternal, newborn, and child survival. Thank you.
Thank you very much, Minister. This is Kudzai Makomba. I'm going to jump in because we might, a moderator seems to have dropped off.
I think I'm back with you. Am I back with you?
Okay, great.
Yes, so something's happened. I'm not quite sure. There seems to be all kinds of strange things happening today, but I think we will get through it. So thank you very much indeed. Dr. Adam, that was excellent. Thank you for that contribution. Let's move to Sierra Leone now, because the Honourable Minister, who's not with us, Dr. Dembi, has been very clear that a bold continental movement for child survival is required. I'm pleased that we have the Deputy Minister of Health for Sierra Leone, Professor Charles Senesi. So, Professor, your minister, Dr. Dembi, did declare that the status of maternal and child health was an emergency in Sierra Leone, and that under his leadership, Sierra Leone would be the first country to publish a child survival action plan. So can you explain what is happening today in your country to address this emergency? And how has your government's response to this challenge changed since the implementation of this bold plan? Please, Professor Senesi, over to you.
Thank you very much, Mr. Moderator, and thank you very much, Dr. Moiti and internal panelists. And I bring you greetings from Sierra Leone, from the leadership of our Ministry of Health, Dr. Austin Dembi, and from His Excellency the President, who is very passionate about human capital development. Indeed, Sierra Leone has come a long way, and I really applaud my boss for that bold move and steps, and we support him in every step of the way. Starting with the maternal mortality in the mid-2000s, 2015, our maternal mortality was about 1,650. And then when we took up office, he's been able to tip that down to 773, 443, and latest facility assessment shows that we're about 300 actually. It is yet to be validated, which means we have made huge gains in the terms of tipping the curve and bringing down the maternal mortality. We are not yet done. We're still working very hard on all fronts. What we need to address, which is what we have the accelerated action plan, is on the child mortality. There were some lapses, and there was a need to have this call to action, which resulted in the published document you've highlighted. And we have the full government support in making sure that at least we pitch our effort more in the area of child health. And what is happening now, I'm sure that we are going to make big gains in the coming years, weeks, and months to come, because government is fully behind us, and we are joining the international community, including the WHO, especially at the last WHO on this action plan on child mortality. So as a government, and it suffices to say that in Sierra Leone, our healthcare, we look at the life stage model, which is what is helping us to actually advance more effort in the area of child mortality and also maternal mortality. The life stage model means that from conception to senior citizens, the focus is on the welfare of the patient at every stage in that journey. If it's a child, we look at all the factors, all the issues that will affect the child, rather than vertical, a more holistic approach. And we are started piloting it in different districts in Sierra Leone. So that's going to help us really to address that holistic approach to childcare, looking at the patient as an entity, and looking at all the issues of diseases, infrastructure, and everything that will affect the welfare of that child. So I think as a government, we are really on track on that. Thank you.
Thank you very much indeed, Professor. Let me ask you a brief follow-up, because it's very important to look at leadership, but the critical nature of these problems. Honourable Minister Dembi, your colleague, did write a powerful opinion piece saying it is time for a bold new continental movement that redefines the way in which we approach child survival in Africa, heightening the level of urgency and seeing governments take back the child survival agenda and making it their own. What else needs to happen? How does one get not just a Sierra Leonean national movement, but a continental movement?
Thank you very much. I think, first of all, realizing that there's a problem, you have 50% of the solution. So if we as a continent actually have realized that we have issues in charge of child health, then we can advance, ways to which we shall work together. One of the greatest things we need to do is working as a team. And that is being exemplified by this call to action. As the proverb goes, if you want to go fast, you go alone. But since we want to go far, we have decided to go as a team. And that teamwork is going to augur for that how do I call it? To augur for sustainability and ownership of this program. And that is what we are doing very much indeed. And also in Sierra Leone, we're working collectively, we need to have a vision. And then we work on healthcare in addressing this particular issue from 4 main domains. Dr. Moiti mentioned primary healthcare. And then we have the secondary and tertiary healthcare. In between, it's the referral assistant, ambulances, mobile clinics, etc., to address child health effectively. And then, of course, we have the health security in terms of pandemics. And so those are the innovative ways we think that the continent can also work with us together. And it suffices to say also that working as a team across the continent, I was in Geneva with the team, we want to improve the quality of care. When you look at patient-centered care, we want to make sure that we have accessibility to health facility right across the country. We are so ambitious in Sierra Leone, we want to have a health facility within 5-kilometer radius. That will really augur well for the population, and we want to reduce that to 2 kilometers, but we will get there so much. And in terms of quality of care, for the children and all the patient-centered care, we're looking also at 4 different domains, which is very critical, and that is what we want every donor, everybody coming into Sierra Leone and the globe in the region to look at. First of all, the infrastructure. Secondly, is the human resource management. I was in Namibia recently with Dr. Moitin. Thirdly, is the supply chain management to make sure that the drug we send, we have monitor them, how they get to the facility, how do we monitor stock out, and fourth is the diagnostics. And we are very deliberate in that. Regionally, we tend to push this forward to make sure that we learn from one another. In terms of infrastructure, it's not only about the physical infrastructure. We need to talk about digitalization of the infrastructure, solarization of this facility, because we have summer all year round in Africa, and also data generation, where you have infrastructure, you solarize sustainable energy, you can generate data, because there you can be able to do a lot of things. Human resource for health is good. I'm happy Dr. Moiten Africa took that bold leadership in Namibia to have a charter now for human resource for health. And then also the supply chain management is what is critical for us in Africa, because we need to see what goes and what comes up. And then of course the diagnostic. So based on that, we have a plan in Sierra Leone which we are willing to share in Africa. I was in WHO. A lot of countries want to come now and learn from that, our patient-centered care, and for our 4 big areas of quality response to our children in this part of the continent. Thank you.
Deputy Minister, thank you very much for what appears to be a very detailed and integrated plan. You've been working very closely with WHO Afro, and then obviously keen to share the knowledge, share the best practice, so others can adopt and learn from what is going on elsewhere. Well, let's move to Guinea now, La Guinea, because we want to highlight the importance of accountability in achieving the ambitious goals of reducing child mortality and meeting the SDG goals. Et maintenant, je vais changer de langue, je vais parler en français. On va discuter de la Guinée. La Guinée est l'un des nombreux pays africains qui ont connu des crises politiques ces dernières années. Je veux parler avec la docteure Diene Fadime Kaba, directrice de la santé pour les familles. Dans votre pays et dans d'autres, cela a rendu les mères et les enfants encore plus vulnérables. La question, quel est l'impact de cette situation sur le ministère de la Santé et sur votre capacité à vous concentrer sur la survie de la mère et de l'enfant? Avez-vous pu mettre en œuvre des idées novatrices en matière de santé et des actions spécifiques en ces temps difficiles? Dr. Diene Fadime Kaba, cette question est posée à vous.
Merci beaucoup, monsieur le modérateur, et merci pour l'opportunité que vous m'offrez de m'adresser au cours de ce panel. Je voudrais parler au nom de monsieur le ministre qui présente toutes ses excuses de n'avoir pas pu être là. Il est à 1000 km de la Guinée, de Conakry, pour ceux qui connaissent, c'est assez loin, et il a des problèmes de connexion. Pour revenir à la question, la Guinée a connu ces dernières années, à l'image de beaucoup de pays de notre sous-région, des crises multiformes, politiques, sanitaires, sociales. Et ces crises ont mis à rude épreuve notre système de santé, notamment pour la continuité des services pour les enfants, la population en général et les enfants et les femmes en particulier. Les taux d'utilisation des services ont diminué pour les principales activités pendant la période. Pour y faire face, le gouvernement, à travers le ministère de la Santé et les partenaires, ont mobilisé des ressources et mis en œuvre des politiques et des stratégies, dont, entre autres, la mise en place de l'Agence nationale de sécurité sanitaire pour la riposte aux épidémies. Parce qu'il est arrivé, par exemple, en 2022, où on s'est retrouvé avec l'épidémie d'Ebola et l'épidémie de Lassa. Et donc, cette plateforme permet aujourd'hui vraiment de répondre rapidement à ces épidémies. Il y a eu également comme stratégie l'amélioration des infrastructures sanitaires, et le renforcement de la disponibilité des ressources humaines à travers le recrutement de nouveaux agents, 2200 agents, agents de santé communautaire qui est en vue, en cours, la contractualisation des sages-femmes pour les mettre dans les zones les plus reculées où il y a vraiment un déficit de ressources humaines. Il y a eu également l'élaboration de la politique et de la stratégie de la santé communautaire, qui est vraiment la stratégie phare du ministère de la Santé, parce que c'est elle qui nous permettra vraiment d'accéder aux personnes les plus vulnérables, notamment les femmes, les enfants et les adolescents dans les zones les plus reculées. Il y a eu également l'élaboration d'un plan de contingence pour la continuité des services que nous révisons chaque année pour pouvoir s'adapter et répondre efficacement aux crises qui, hélas, font partie de notre quotidien, on peut dire de l'écosystème de notre région actuellement. Nous avons utilisé aussi le plaidoyer pour le financement de la santé, aussi bien le financement à travers les ressources endogènes qu'exogènes. C'est pour ça que nous travaillons actuellement avec toutes les sociétés privées telles que les miniers. Nous faisons des plaidoyers à leur endroit pour qu'ils s'imprègnent dans le financement de la santé, notamment la santé des enfants et des femmes. Il y a aussi, toujours dans le cadre de la réduction de la mortalité infantile, nous avons adhéré à l'initiative d'indépendance vaccinale il y a, en tout cas, il y a 1 mois et demi, juste avant d'aller à l'OMS. Tout ceci pour régler la question récurrente de disponibilité des produits, surtout des produits de qualité de vaccins jusqu'au dernier kilomètre. Il y a aussi, toujours dans le cadre de l'amélioration de la survie de l'enfant, il y a eu l'élaboration d'une stratégie nationale de relance du PEV qui prend en compte un certain nombre d'actions spécifiques sur tous les piliers qui peuvent rendre le PEV performant. Nous avons évidemment au niveau du pays le plan stratégique SMANIA et le dossier d'investissement qui soutient ce plan pour faciliter la mobilisation de ressources en se focalisant sur certaines interventions prioritaires et des zones prioritaires pour accélérer les progrès.
Ah, c'est très impressionnant, Dr. Kaba, mais j'ai encore une question. Sachant que la responsabilité est essentielle, comment pouvons-nous garantir l'engagement et la redevabilité des gouvernements et des bailleurs de fonds internationaux? Encore une question pour vous, Dr. Kaba.
Pour la responsabilité, on peut voir ça à 2 niveaux. Le premier niveau, c'est vraiment au niveau pays. Il a été élaboré, le gouvernement a mis en place les lettres de mission et les contrats d'objectifs au sein même du département pour pouvoir évaluer les uns et les autres sur la base des missions qui sont confiées. Ensuite, il y a une évaluation des départements, de tous les départements par le Premier ministre, chef du gouvernement, toujours dans le cadre de renforcer vraiment la redevabilité. Et en ce qui concerne les partenaires, au niveau pays, d'abord, la santé de la mère et de l'enfant est maintenue comme une priorité. Et cela se reflète dans tous nos documents stratégiques. C'est vraiment la priorité parmi les priorités, si on peut dire ainsi, dans un pays où il y a beaucoup de choses à faire. Et élaborer également le plan d'action d'accélération de la survie de l'enfant. Suite au forum sur la pneumonie, les pays ont été encouragés, parmi les engagements du pays, c'était vraiment d'élaborer, en tout cas, ce plan un certain nombre d'actions en vue d'accélérer, sur lesquelles on peut mettre l'accent pour accélérer les progrès vers l'atteinte des objectifs de développement durable concernant la santé de la mère et de l'enfant. Pour ce faire, nous avons élaboré une stratégie, un plan d'accélération de la survie de l'enfant qui est en cours de finalisation et qui va se concentrer sur quelques éléments essentiels, mais qui peuvent rapidement faire le progrès. Et au niveau des partenaires, il y a évidemment un cadre de concertation qui existe pour l'harmonisation, en tout cas, des interventions des partenaires et de les aligner sur les priorités de notre pays.
Dr. Kaba, merci beaucoup pour cette réponse de la part de la Guinée. Je vais me diriger maintenant vers le Mali. Et Dr. Guindo, la question, quels sont les principaux défis à relever pour augmenter les dépenses nationales en matière de santé, et plus particulièrement de santé maternelle et infantile? Et quelles sont les idées audacieuses et les actions spécifiques que le gouvernement du Mali a mises en œuvre pour augmenter les dépenses? C'est à vous, Dr. Guindo.
Okay. Bonjour à tous les participants. Merci de me poser vraiment cette question. Donc, les défis en matière, comme vous le savez, vous connaissez un peu la situation particulière, en tout cas, du pays. C'est vraiment un défi d'accès, un défi d'accessibilité géographique et accessibilité financière, en tout cas, pour les cibles, en parlant bien entendu d'équité. Et les défis, encore une fois, c'est les défis des ressources humaines qualifiées, non seulement par rapport à non seulement à leur nombre, mais surtout à leur maintien, surtout dans les zones d'accès difficiles. Et aussi l'acheminement vraiment des intrants en matière de santé et des médicaments un peu qui couvrent le pays. Et aussi, il y a un défi vraiment aujourd'hui qui est là, c'est-à-dire l'engagement communautaire. Comme vous le savez, le Mali est parti pour la santé communautaire depuis. Alors, il faudrait qu'il y ait plus d'engagement, plus que pour que la disponibilité des données probantes, qui est un véritable problème, et que ces données probantes soient traduites au niveau de la communauté pour comprendre leurs responsabilités, afin même de participer à leur développement. Donc ça, c'est un véritable, en tout cas, défi, entre autres, en tout cas, qui sont là. Alors, les idées, les actions audacieuses, on peut les dire, oui, idées audacieuses. Donc, nous sommes partis pour la couverture sanitaire universelle. Et pour ce faire, donc ça, c'est pour une sorte de mélange vraiment de la protection, des systèmes de protection sociale, donc contributive et non contributive. Ce qui nous a permis de mettre en place les assurances maladie obligatoires. Ça, c'est pour les contributifs, les salariés. Mais surtout non contributifs, où nous avons mis le RAMED, c'est-à-dire le RAMED qui prend en tout cas les indigents, qui sont très, très fréquents et qui sont très nombreux, en mettant en place le registre social unifié. Donc, il nous permet vraiment, encore une fois, d'accompagner ces indigents pendant, en tout cas, une période bien donnée, 3 ans, pour que réellement ils puissent être pris en charge sur le plan sanitaire, mais aussi qui les permet aussi de quitter encore au stade d'indigénat pour venir vraiment dans la vie active. Nous sommes aussi, l'idée audacieuse, c'est un tout petit peu de recenser les déplacés, comme vous le savez, compte tenu de notre situation particulière, en tout cas, les déplacés, de les mettre bien entendu dans une base de données digitale, de les apporter vraiment les stratégies en tant que telles. Mais stratégies audacieuses nous nous sommes dit, bien entendu, compte tenu des dépenses, en tout cas de santé, et compte tenu vraiment de la situation du pays, qu'il faut renforcer le système de prévention, en renforçant vraiment la vaccination. Et cette vaccination, bien entendu, en élargissant pendant un bon moment les cibles et en essayant, bien entendu, d'identifier les eurodoses et de les apporter, en tout cas, les interventions nécessaires. Renforcer encore une fois les systèmes de prévention, en tout cas, surtout en matière de planification familiale, pour réduire au maximum, bien entendu, et pour contrôler un peu, si vous voulez, la natalité, qui nous permet en tout cas de lutter contre cette mortalité. C'est entre autres, et puis encore une fois, pour la prise en charge la qualité des services. Je crois que nous avons un plan oxygène, alors qui nous permet aujourd'hui de renforcer en matière d'oxygénothérapie et de prise en charge de nos centres de santé de référence, c'est-à-dire, et encore une fois, de réguler notre système de référencement et tout en mobilisant encore, renforçant notre système communautaire qui est déjà connu, en mettant en place une sorte de plateforme qui tournent autour des agents de santé communautaire qui ont un niveau assez élevé pour la prévention ou la prise en charge précoce des affections, entre autres.
Merci, Dr. Gundu. Il faut profiter des systèmes modernisés, mais il y a beaucoup de problèmes pour chaque pays. Les pays en voie de développement et les pays plus riches. Mais tout le monde doit prendre des décisions difficiles concernant les dépenses de santé, compte tenu des contraintes en matière de ressources. Donc, comment le ministère de la Santé du Mali a-t-il utilisé des données probantes et des analyses pour identifier les priorités en matière de santé? Et quelles sont-elles?
Ok. Monsieur, merci beaucoup pour cette question. Et on sait bel et bien que les ressources se font rares. Vous avez vu le collectif budgétaire, en tout cas tout de suite du gouvernement, où nous avons priorisé vraiment surtout la défense et l'énergie. Alors la santé, en tout moment, comme vous le savez, nous gérons en tout cas les conséquences, comme je l'ai dit chaque fois, des bonnes et des mauvaises choses. Et plus il n'y a pas de budget, plus les besoins s'augmentent. C'est un tout petit peu d'organiser les partenaires. Alors, les partenaires qui sont organisés, et nous avons les partenaires qu'on appelle les partenaires du dialogue, et qui sont là, et qui discutent de façon périodique vraiment avec le ministère de la Santé pour exposer les priorités à partir des données probantes. Et mieux encore, ce sont ces données probantes qui sont transformées en actions pour montrer en tout cas au pays, pour faire ce qu'on appelle une planification essentielle, comme les soins de santé prioritaires nous demandent. Une planification essentielle au niveau vraiment de la communauté, au niveau d'abord communautaire et encore au niveau de la prise en charge, essayer d'aller vraiment vers une spécialisation, en tout cas non seulement de nos hôpitaux de troisième référence, mais de renforcer en ressources humaines et aussi bien en équipement vraiment les centres de santé de référence. Donc, c'est ce qu'on appelle encore une fois les planifications essentielles. Et maintenant, le gouvernement, selon vraiment, aujourd'hui, nous sommes à l'ère de la digitalisation, et cette digitalisation qui nous permet d'avoir en tout cas les données à temps réel et vraiment de les transformer en informations sanitaires et pour prendre des décisions. Et alors, en ce moment, en termes de priorité, c'est vraiment un cadre de concertation quand même qui est là entre vraiment le gouvernement et les partenaires, ce qui permet encore une fois de prioriser, de faire la priorité des actions afin qu'il y ait une synergie d'action, en tout cas pour endiguer cette période aussi difficile.
Dr. Gindu, merci beaucoup. Thank you very much to our panelists so far. Now, I'm looking and I can see in the chat and in the grid, there are lots of questions coming in, and I want to address them to some of our panelists. So I'm going to start off with Dr. Mweti, and one of our participants is asking you to comment on the link between child and maternal health, nutrition, and agriculture policies. How do ministries of health and agriculture need to work together on incentives and guidance to advance development? So Dr. Mweti, could you respond to that, please?
Thank you. Thank you very much. That's a very important question that's digging into what we always talk about, multi-sectoral action. And I mean, I think in this specific case, of course, when we're talking about access to nutritious food, then there needs to be a discussion between those who are developing agriculture as a sector, both for local and increasingly for international as part of trade, and those who want to make sure that what is grown is what will contribute to health. So clearly, if within those mechanisms that are created for the contribution of other sectors to, wait a minute, yeah, the contribution of other sectors to health are being discussed, there will be discussions about what is it that's nutritious that should be made available. Where should we focus in terms of growing food that can be healthy, available, accessible, including how to transport it to where families can get access to it easily. So this should be part of the conversation. The Minister of Health needs to define what is it that's a healthy package for the nutrition of children, mothers, other people, and including the fact that we are seeing a growing problem of non-communicable diseases, some of which are related to diet in Africa. And then how that food can be made available, accessible through investment in agriculture that's appropriate and affordable to families. So for me, that's an example of multi-sectoral collaboration around the issue of the health of mothers and children, which hopefully can benefit both sectors. If this is food that's healthy and communities are aware that this is what we need to be buying, it'll help to create a market for what is grown by agriculture. And on the other hand, then the food that's needed will be available for families to have access to affordably, working with, of course, partners who need to support this work. We work very closely around other areas with the FAO as WHO in health, and working together, we can help to advise both of those sectors on this.
Dr. Moti, thank you very much indeed for that comprehensive reply. It's a huge area, and people talk about multi-sectoriality all the time, but how do we get it to work? We have a question here. I think it is for Dr. Adam, representing Somalia. And the question is, well, could you please outline some of the major challenges that confront governments who want to increase domestic spending on health and maternal and child survival in particular? How do countries make the case to their ministries of finance that investing in child health is investing in the economy and the future of the country? Dr. Adam, I think that will be easier for you to answer because I think you are doing that already to your finance minister.
Thank you. Thank you very much. There are a lot of challenges facing Somali government. As you know, we were in civil war for a long time since the last government collapsed in 1990. After that, the country experienced decades of instability and lack of security. And most of health infrastructure and health system during that period has collapsed, had been collapsed. So now we are in the era of re-establishing health infrastructure and re-establishing, re-strengthening health system. The most challenging now is that in a large area still in the country are not in the government control and is inaccessible by health services. We have succeeded during the past 2 years. We have succeeded to liberate and a lot of large area from the terror group, and some of that area now there is service delivery, whatever the quality and whatever the capacity. But still, there are villages, districts, and rural area that is inaccessible, and that the mothers are dying for lack of and health service and lack of maternal and child health centers and lack of safe delivery. Until we succeed to liberate whole of the country, there is a challenge, and decreasing maternal mortality is not will not be successful as we want. So the other challenge is financing. There is a very limit. Domestic financing of the health is very limited because the income of and revenue generation of the government in general is limited, and the whole effort of the government is directed toward the security side and the liberation of the country. So the contribution of the government fund to the health sector is too limited and too short. So we are mostly dependent on our donors for continuation of the primary health care services. Now we got and we are financing health service delivery in 5 regions for Damal Ahmad project financed by World Bank. We wish to expand such projects financed by our partners and friends. So there is also a little portion of project called Better Life, financed by UK, also working in 14 districts. We wish to expand such services, and we want also to persuade the Minister of Finance and negotiate with them to increase the contribution of the government toward the health sector. So the next, the upcoming years, we wish to see improvement of the health sector in Somalia and increase the contribution of the government by the funding of the health sector in Somalia.
Thank you very much indeed, Dr. Adam, for that. Peut-être que je vais parler maintenant en français, juste pour le moment. Dr. Guindo, je pose la même question à vous. Alors, pour essayer de convaincre vos collègues, donc le ministre du chancelier de l'exchequer, les ministres qui gardent l'argent, comment convaincre vos collègues que investir dans la santé, c'est investir dans le développement?
Ok, merci en tout cas pour cette question. Comme vous le savez, c'est à partir des données. On traduire ces données vraiment en information. Et c'est de cela qu'il s'agit. Nous pouvons avoir les indicateurs. Les indicateurs, vraiment, c'est technique. Mais maintenant, comment traduire ces indicateurs, en tout cas sur la santé de la population, pour qu'ils puissent comprendre? Maintenant, madame, au niveau du ministère, à chaque semaine, de façon hebdomadaire, nous présentons vraiment les données par rapport non seulement à la situation épidémiologique, mais aussi à la situation, sur la situation de la mortalité maternelle, infantile et néonatale, donc au gouvernement. Et pour dire encore une fois que, et c'est là, dans tout le Mali et sur toute l'étendue du territoire, et donc on essaie quand même de présenter cela au gouvernement pour un plaidoyer pour qu'ils puissent comprendre et dire tout simplement que ça, c'est un tout petit peu les données ou bien les décès ou les situations au niveau de nos structures de santé. Mais quand on fait une projection, bien entendu, dans la communauté, on peut avoir, bien entendu, parce que les décès communautaires, il ne faut jamais les négliger, on voit tout simplement pour amener vraiment le gouvernement à comprendre et réellement l'engagement qu'ils peuvent faire, en tout cas aujourd'hui, malgré la situation sur l'état de santé de la population. Et qu'à cela ne tienne, ce sont ces mêmes données qui nous permettent, en tout cas, de façon, des cadres de concertation qui sont donnés avec les autres partenaires pour qu'avec cela, nous puissions, en tout cas, mobiliser de l'argent. Donc, c'est à partir vraiment de ces données et encore une fois, et les lobbying, en tout cas, les visites et surtout le leadership, en tout cas, du ministre dans le gouvernement qui permet vraiment, encore une fois, malgré les budgets annoncés, mais de faire vraiment certains budgets additifs pour faire face à des situations particulières, pour des cas aussi particuliers, surtout en matière de santé maternelle qui se présentent. Voilà vraiment ce que nous faisons, parce qu'à chaque semaine, de façon hebdomadaire, nous montrons en tout cas au gouvernement, au conseil de ministres, les données par rapport non seulement à la situation de la santé même en tant que telle au gouvernement.
Dr Guindo, merci beaucoup. Peut-être que je peux poser la même question à Dr Kaba de la part de la Guinée.
Ok, merci beaucoup pour de me donner encore l'opportunité de parler sur les questions de financement. Je pense que nos pays n'ont de choix aujourd'hui que de faire en sorte de mobiliser le maximum de ressources, aussi bien, surtout des ressources endogènes, pour en tout cas le financement de la SMNIA, la santé reproductive maternelle, néonatale et infantile globalement. Pour ce qui concerne notre pays, un pays qui est un pays à grande potentialité agricole, un pays minier, mais dont les indicateurs restent quand même toujours en deçà en tout cas parmi les plus précaires au niveau de la sous-région. Donc, le gouvernement guinéen est engagé vraiment à inverser cette tendance à travers en tout cas le choix de certaines stratégies comme la santé communautaire, comme on l'a dit tout à l'heure. Nous avons engagé aussi des bases pour aller vers la couverture santé universelle, même si ce processus est long et complexe, nous en sommes conscients, mais les étapes sont en train d'être franchies et nous avons déjà une feuille de route pour ce faire. Et aussi, engager vraiment les partenaires à travailler, les ONG nationales, la société civile, à travailler le secteur privé surtout, de tous ordres, le secteur privé minier et non minier, à mobiliser des ressources internes pour pouvoir faciliter, en tout cas, encourager les partenaires à nous accompagner. À titre d'exemple, nous avons dans une commune rurale dans la région urbaine plutôt dans la région de Mamou, qui, à travers notre plaidoyer, pour investir 2% de leur budget local pour la planification familiale. Cette commune rurale aujourd'hui a commencé à faire ça. Nous avons eu les premiers résultats. Ils ont opté vraiment octroyer 2% de leurs ressources pour le financement des activités relatives à la planification familiale, par exemple, qui est une stratégie vraiment de réduction de mortalité maternelle reconnue par le gouvernement guinéen à travers le ministère de la Santé. Je voulais simplement dire qu'il y a des opportunités. Il y a des opportunités à travers l'engagement des partenaires qui accompagnent des pays, mais aussi une gestion vertueuse et des ressources endogènes, l'implication du secteur privé dans la mobilisation des ressources peut aider vraiment à améliorer les indicateurs de santé de façon durable et de manière à avoir des familles en bonne santé et investir vraiment dans le capital humain à travers une très bonne nutrition qui est aussi une priorité du ministère de la Santé par la création d'un comité multisectoriel des systèmes alimentaires et nutritionnels qu'on appelle comme ça, qui regroupe tous les départements, le ministère de l'Agriculture, du Commerce, de l'élevage, tous les départements sensibles et spécifiques à la nutrition pour pouvoir, qui est sous la présidence de Monsieur le Premier ministre, pour pouvoir adresser la question de la nutrition, qui est un domaine qui permet non seulement qui facilite l'atteinte vraiment des autres objectifs du développement durable. Voilà ce que je peux dire concernant la Guinée. Merci.
Merci beaucoup, Dr. Fadima Kaba. Thank you very much indeed. I see some of you are complaining that I'm switching languages. I'm sorry. Sorry to confuse you. That was not my intention. But of course, we have people from primarily English-speaking non-indigenous countries in terms of the language, and also French, so Anglophone and Francophone. So I'm trying to do justice to both, but I will let you know in advance when I'm going to switch languages. Thank you very much. Final question for now. Let me go to Professor Senesi, who is the Deputy Minister of Health and Sanitation in Sierra Leone. Can I ask you this? What are the challenges in implementing high-impact, low-cost, and evidence-based interventions, such as integrated community case management or integrated management of childhood illnesses? And can you include in your response a reference to rural communities, so out of the city center, because a number of our participants, our viewers, are asking about rural communities. So over to you, Professor Senesi.
Thank you very much, dear moderator. Yeah, indeed, some of the challenges in rolling that out is mobilizing of resources, human, material, and financial. And as I said earlier on, a greater percentage of our investment is in primary healthcare. Almost 80% of our ministry investment is in primary healthcare. Now we're catching up with secondary and tertiary. So I think the greater challenges is in terms of mobilizing this need for resources, which is why we really do a lot more on domestic financing, innovative ways of raising money so that we can able to finance our integrative approach. And we reach out a lot to the community, the hard to reach areas, which is the passion of some of us. I've been 30 years out there in all sub-Saharan Africa countries, running mobile clinics, knowledge transfer exchange, focusing on maternal and child health issues. So that's been my passion, and I'm happy that the vision of our ministry is in that direction. So really the issue will be the mobilizing of resources, and then we're doing a lot more on domestic financing, and we hope we can reach out to partners, because as you know, we cannot do it alone as a government. We depend a lot on our, development partners, we call them. So at least we can all sort of, they can complement our efforts to maximize our output in child health. I think that's what we do. Thank you.
Thank you very much. So we're now going to move into the final round of questions, brief responses, because we want to leave people here on this webinar thinking about future actions, moving from rhetoric and policy to real action on the ground, helping people. So Professor Senesi, I'm going to go straight back to you. What leadership action are you committing to in order to support and grow the child survival movement in Sierra Leone?
I think it is normally said that with political will, we can do a lot. So first of all, we have a lot of political will supporting our actions. And then we have generated enough evidence, pieces of evidence, to lay before the Minister of Finance so as to support our action. So I think those are the things we are really addressing in that area, if I cut it short.
Thank you very much indeed for that. Okay, I'm now going to move to French for a moment or two. So please, those of you who are complaining that I'm speaking in English, now you can switch to the French channel so that I can ask this question of Dr. Kaba. Donc, c'est la question, OK? Maintenant en français. Quelle action de leadership vous engagez-vous à mener pour soutenir et développer le mouvement en faveur de la survie de l'enfant dans votre pays? S'il vous plaît, Dr. Kaba.
Okay, merci beaucoup. Au niveau pays, nous avons élaboré les plans d'accélération et de l'atteinte des cibles relatifs à la santé maternelle, néonatale et infantile, qui mettent l'accent sur des interventions clés à mettre en œuvre pour les prochaines années. Renforcer aussi le système de santé à travers l'amélioration des plateaux techniques, des installations d'eau potable, d'électricité et d'assainissement. Renforcer la disponibilité continue des ressources humaines de qualité et adaptées aux besoins des systèmes de santé, ainsi que la formation continue des prestataires. Renforcer la disponibilité des médicaments, des produits de santé et intrants de qualité, car sans médicaments et produits de qualité, il n'y a pas de service. Voilà. Maintenant, au niveau... Oui. Allô?
Si vous voulez
m'entendez?
finir, vous pouvez finir.
Voilà. Donc, au niveau national, je pense que ce sont des interventions à faire. Et au niveau global, régional, par exemple, nous pensons qu'il faut poursuivre le plaidoyer auprès des pays pour l'élaboration et le financement des plans accélérés de réduction de la mortalité infantile. Et de soutenir aussi la mise en œuvre des plans pays, parce que les plans pays, certains pays ont élaboré des plans accélérés de suivi de l'enfant, et créer un cadre de concertation pour le suivi des progrès dans la mise en œuvre de ces plans et appuyer les pays plutôt dans la mobilisation des ressources pour le financement de nos plans, y compris les ressources domestiques. Merci beaucoup.
Merci beaucoup, Dr. Taba. Maintenant, on sait ce qui se passe à Guinée, mais alors, quant à d'autres pays, qu'est-ce qui se passe au Mali, qu'est-ce qui se passe au Burkina Faso, qu'est-ce qui se passe au Ghana, Nigeria, Dr. Gildo, dans votre pays? OK.
Ok.
La
Merci
même
beaucoup.
question.
Oui, la même question. Donc, je crois que c'est, pour le moment, comme on l'a dit, hein, par rapport à la communauté, c'est de renforcer la santé communautaire, puisque d'ores et déjà, la santé étant déjà attribuée aux collectivités, alors c'est de capitaliser et de rendre vraiment opérationnel les ressources mobilisées au niveau vraiment des collectivités pour l'utilisation, en tout cas au niveau communautaire. Et le renforcement vraiment des différentes plateformes communautaires nous permet encore une fois vraiment d'agir très rapidement sur les maladies évitables. Et comme je l'ai dit, et renforcer vraiment le système de prévention à travers vraiment la vaccination, les mesures de prévention et les pratiques familiales essentielles. Et donc, ça, c'est vraiment au niveau communautaire. Et essayer, encore une fois, à partir des données probantes, parce qu'aujourd'hui, au niveau du Mali, nous avons les agents de santé communautaire qui ont un certain niveau et qui sont vraiment dans la digitalisation des données. Comment maintenant rendre vraiment ces données et les transformer en informations au niveau communautaire, hein, pour que réellement la communauté puisse prendre leur propre avenir en matière de santé en main. C'est-à-dire lorsque vraiment ils ont l'information, et que ces informations vraiment les permettent de prendre des décisions. D'abord, ça nous permet encore une fois d'utiliser de façon optimum les ressources aussi faibles que ça. Et encore une fois, dans nos cycles de planification, planifier vraiment les interventions aujourd'hui sur les besoins essentiels, comme vraiment les soins de santé primaire nous indiquent. Alors, donc, c'est sur les besoins essentiels. Et comme on le dit au niveau maintenant de la prise en charge, c'est de renforcer le plateau technique et en utilisant vraiment, en essayant vraiment de spécialiser nos hôpitaux de troisième référence, mais aussi, surtout, nous avons un système de référence évacuation qui est mis en place et qui permet vraiment de prendre en charge des cas aussi compliqués avec un système de prise en charge très précoce. Mais aussi, essayer de façon très, très rapide de mettre les plateformes, en tout cas les cadres de concertation entre le ministère de la Santé et ses partenaires, qui nous permet encore une fois de réorienter nos interventions et d'indiguer à chaque fois qu'un goulot d'étranglement est déjà vu et de proposer vraiment les solutions adaptées à cela. Donc, ça, ce sont vraiment des systèmes qui sont là parce que compte tenu et de créer des stratégies novatrices. Nous savons que nos stratégies, surtout fixes, avancées, équipes mobiles, alors c'est là, mais aujourd'hui, compte tenu du contexte, essayer de faire cette planification en adaptant nos stratégies d'intervention pour l'accès, en tout cas, de toute la population, puisque nous avons vraiment des déplacés, nous avons encore des réfugiés, nous avons des zones d'accès difficiles. Donc, créer vraiment des stratégies adaptées pour que ces gens puissent accéder vraiment aux soins essentiels en tant que tels. Et nous avons notre plan, comme elle vient de dire, beaucoup de plans sont élaborés, les plans de survie, les plans d'oxygène, nous avons le plan sec, en tout cas, qui est là, donc ils sont là, mais tous est tributaire, en tout cas, du problème de financement, c'est de travailler comme il y a un qui l'a dit avec le ministère des Finances pour qu'ils puissent comprendre quelle est la place vraiment de la santé dans le défi, en tout cas, d'un pays. Je vous remercie.
Thank you very much indeed for that response, Dr. Gindo, explaining what you are going to do when it comes to leadership of this agenda in your country, Mali. Let me turn now to Dr. Ali Haji Adam, the Minister of Health and Social Care of Somalia, who was a driving force behind the adoption of this particular resolution at the World Health Assembly. Tell us more about the leadership action you are committing to going forward in your country. And can you tell us which specific stakeholders and agency that you are going to call upon for support as part of your commitment to action, Dr. Adam?
Thank you very much. Really, adoption of this resolution, there is most technical agency supported us is WHO. We were the resolution we were talking about on behalf of Emerald, Eastern Mediterranean region, and we submitted the resolution on behalf of Eastern Mediterranean region. So they gave us technical support. Our family health department director and my health policy advisor, Dr. Mohamed Abdi Jama, this and WHO technical team was paid and a lot of efforts to make successful the submission of this resolution. And they were a couple of months, they were negotiating with the countries for submitting and approving this resolution. And on the other hand, we wish that our donors will support and the implementation, acceleration of the implementation toward reduction of maternal and neonatal and child mortality rate and in the concerned countries who cannot achieve the desired goal in 2030 in general, and especially in Somalia, which is the worst country in the mortality of mother and child. We wish they're standing with us to accelerate these efforts. Especially, we wish and the FCDO of UK and also and World Bank and to expand their support in the health sector to able to achieve the decided goal in 2030. Also, we wish our UN agencies like UNICEF, WHO, and UNFPA their contribution to expand and increase their contribution in Somalia. Also, other national, international NGOs and partners. We wanted to take and steps toward and achieving and the decided goal in 2030 by creating a lot of health centers in the rural area, by training a lot of health professionals and midwiferys to decrease to make available safe delivery for mothers of Somali mothers in the villages and rural area. So we hope the support of our partners and donors and our friends toward making this resolution and successful in the implementation.
Very good. Dr. Adam, thank you very much indeed for all of that. Plenty to do, a huge amount for the incoming regional director to focus on, to help countries move from resolution to reality. So I'm now going to call upon Dr. Mwete, who, you are now the outgoing regional director. You've done so much great work over the years. This resolution calls on the leadership of the World Health Organization to prioritize this unfinished agenda. So thinking of Africa specifically, and we have people joining us from Southeast Asia, from South Asia, from all over the world, from Peru. But thinking of Africa specifically, what should the incoming regional director be doing to help countries move from resolution to reality? Dr. Mwete.
Okay. Thanks very much, Henry, to that reference to my imminent transition. So I'll become an NGO activist. So I'm going to walk across the street and be an activist, saying to everybody, "Hey guys, let's get this done." But no, I mean, I think going back to the political commitments that have been made, certainly we need to make reference to those. We need to work with the African Union to encourage and remind our political leaders of the commitments that they have made at the level, as I said at the start of the African Union, and also in the resolutions that are adopted in WHO. One of the things that I find very effective in reminding leaders of the need for them to engage directly as well is to do scorecards. So to have a table showing you're here and your neighbor next door is better than you, and it grabs the attention of leaders like nothing I've ever seen before. So that can be the start of saying, leading to all the things that have been talking about, allocation of resources for health, and also engaging not only at the ministerial level, but at the highest political level with international partners in negotiating for funding for health, and specifically for this area of health, because you need the engagement, as we have seen in Sierra Leone, and no doubt in other countries, not only of the ministers, but also of the leaders when they sit with the major funders for development, like the African Development Bank, the World Bank, bilateral partners, to ensure that in addition to other sectors, the health sector gets its proper place for the development of human capital for economic development in the countries, which includes this. So that's one of the things that I would advise my successor to do. Secondly, referring to financing, we can be much more efficient in the use of the resources that are allocated to health, both national resources and partner resources. As I've said, if we reduce the fragmentation, the duplication in international financing, following some of the directions that are coming, somebody needs to monitor to make sure that this shift in habits and ways of working that have been developed over many years does happen, and that we really become more efficient. We pool our funding together. We work in those planning mechanisms that the ministers have referred to together to ensure that we are rational in allocating resources. One of the ways of making sure of this is really ensuring that we decentralize the financing. We let the primary healthcare money actually reach the peripheral level, because in many of our countries it's in the plan, but the disbursement of the funding is important. So one of the things we need to be doing as WHO as well is monitoring and supporting in terms of where really does the money land. We can increase significantly the efficiency of hospitals, because much of the funding that is received still ends up in hospitals, and support then the money getting out there. So I would continue what work that we're able to do in WHO, just to analyze the efficiency of different levels of the healthcare system. Again, the power of data, and be able to show to the leadership, the national leadership, the ministers, the program managers, and the partners where actually money is going, the efficiency with which it is being spent, etc. So, and then finally, advocacy. Helping to understand how to work with the other sectors that are so important, and helping to put together those platforms and ensure that they really do grow. And then finally, using technology. So a couple of the ministers mentioned technology. It can work at all levels. It can work at the most peripheral level, and it can be used at the most central level. One of our duties as WHO is to document experiences, learning, and disseminate that. So I think that's also a very important role that we need to invest more and more in as WHO. Here's a good experience in one country, share it, among our member states, so we don't relearn the same things, make the same errors in a number of countries. So those are some of the things that I would say. And finally, we must continue to be advocates for what happens in communities. And that needs to translate in terms of resources, influence, engagement. And I think the decision makers will very much value that feedback that comes from the operational level, the most peripheral level. As I said, I'll be an activist across the border, the boundary, so to speak, supporting.
Dr. Moeti, you'll be most welcome to be so, poacher turned gamekeeper or vice versa. Thank you very much indeed, and all the best with your future activism. One or two people have pointed out that I haven't asked their questions exactly as they wrote it. My apologies for that. I'm not sitting here on my own, as it were. I mean, of course, it's a team, and the team will moderate the questions and paraphrase in order to try and get the sense across. And apologies if that didn't happen exactly as you wanted it to be done, or if we weren't able to get to all of your questions. So that having been said, now we were hoping earlier to be joined by the Honourable Minister, Dr. Dembi from Sierra Leone, the Health Minister, and he was going to essentially issue a call to action, because in a few weeks' time, we're going to have the WHO Africa Regional Committee meeting in Brazzaville, Republic of Congo. He's not with us, but Professor Senesi is his deputy, the Deputy Minister of Health and Sanitation for Sierra Leone. Let me pass that task on to you if you're willing to embrace it, Professor Senesi. Just a brief call to action, because we're looking forward to the WHO Afro Regional Committee meeting in Brazzaville, Congo. Over to you. You are muted. You have to unmute yourself. Yes. Professor Senesi.
Apologies.
Yes.
Apologies. Indeed, on behalf of my boss, I think we issue this call to action for accelerated action on child health, and then and look for further engagement. As we know, in Sierra Leone, we continue to be deliberate in child action, and then we have lots of technologies now that we have really put into operation, such as the press track that monitors in real time the pregnant women and in 350,000 all across Sierra Leone. And then we have a new app that will monitor the vaccination dropout, etc., right across the country. So we are really deliberate. And then someone mentioned earlier on, these are all the prelude to our call to action. The ban on child marriage in Sierra Leone is not illegal to have child marriage in Sierra Leone, because we know all the attendant complications that comes with it, and in terms of all the issues around it. And so I think that is where we based our call to action before we meet in Brazzaville. And on behalf of my boss, I really like to do that, and then look forward to more holistic approach, more colleagues joining us in this accelerated call to action for child health. I thank you very much.
Thank you very much indeed, Professor. And I'm delighted that so many of you have been engaging, and a number of you, well over 100, are still on this call. So let me thank you for your attention. Thank you for your engagement, and thank you for your willingness to be part of this struggle, because the improvements that have been made are nowhere near as good as they can be and will be if we work together across silos with depth and with energy, and persuade ministers of finance and other government departments that investment in health, particularly at a very early age, nursing mothers and newborns and infants, will improve the quality of health and the development of the entire country. So let me thank Dr. Moeti, Dr. Adam, Professor Senesi, Dr. Fadima, and Dr. Gindo for being an excellent panel today. Thank you very much to colleagues from the Child Health Task Force and Market Access Africa, who are part of Child Survival Action. And that was From Resolution to Reality, Accelerating Progress on Maternal and Child Survival in Africa. I'm Henry Bonsu, and I hope to see you next month in Brazzaville, Republic of Congo. Thank you very much indeed.
Thank you very much.